first. All three. Okay. We see three members here. You're welcome to make a statement on your proposals. We're doing them in order. Walter's not here, though, right? So, yeah, let's start with Assemblymember Gibson. Looks like he's first in order on the agenda. And then we'll go to Assemblymember Gaines.
Thank you very much, Mr. Chair and members. I want to thank you for giving me this opportunity to present the personal needs allowance for your consideration to be added to the budget. The personal needs allowance is $35 allowance to provide to Medi-Cal recipients who are residents of nursing facilities. Residents are required to contribute their outside income to share in the costs and given $35 their own personal needs. The current $35 allowance was established in 1984, over 30 years ago. When we compare that to today's dollar, this represented an inflation rate of over 125%. Across the nation, many states have increased their personal needs allowance to where California is now the bottom of 20% of the states, even though California also has one of the highest cost of living in the country. With the lifetime contribution seniors have made to our community and to the state, the least we can do is give them a decent allowance that provides dignity and independence of living. So I request for your support in this manner.
Thank you, Assemblymember. Let's go to, does DHCS have any comment on this?
No, we do not.
Department of Finance?
Yeah, I'm with Department of Finance. I'm just going to make a comment for this and the rest of the other proposals by the members. As I stated earlier, these are not part of the governor's budget, so we're not in support of these proposals.
LAO? No comment. How about DPH? No comment. Okay. Thank you. Do we have any comments from the public? Yes. Please step forward.
Good afternoon. My name is Lisa Coleman. I'm the Executive Director with the California Long-Term Care Ombudsman Association. We respectfully ask for this increase. According to the National Center of Health Statistics, more than 50% of nursing home residents have no close relatives. 46% have no living children. It's estimated that 60% of the residents that live custodial long-term care in California's skilled nursing facilities have no one to help them. That $35 has to provide them with all of their extra clothing allowances. It has to provide for shoes, the occasional treat of a candy bar. We ask for your support.
Thank you. Seeing no additional public comment. Any questions or comments from members? Okay. Seeing none. Thank you, Assemblymember Gibson.
Thank you.
No action, right? So next is Walter. Okay. Next, we'll go to Assemblymember Gaines for your diabetes grants position proposal.
Last year, I called for an audit of the former California Diabetes Program in order to ensure that the funds were being spent for an appropriate purpose. The auditor, in her report, mentioned that what little funds the program received were in fact being used appropriately. However, the auditor highlighted the lack of opportunity for the program to go out and find funds at the federal level due to the very small size of the chronic disease branch, which has replaced the diabetes program. Since the branch is funded by existing federal grants, the employees of the branch are greatly limited on the scope of their responsibilities in actively seeking out numerous grant opportunities. The auditor also mentioned in her report that because the branch does not have a formal process, nor the staff, to search for diabetes-related grants, she recommends that one single staff position be created to compete for more grant opportunities. The need for this position is highlighted by the fact that the auditor identified more than 40 different grants related to diabetes that the branch could have applied for and didn't. Some of these grants were worth up to $500,000 per year. In the same report, the auditor also highlights that California ranks 50th out of 50 in per capita spending on diabetes. With the cost of diabetes rising to an estimated $29 billion per year, it makes complete fiscal sense for this one position to be created within the chronic disease branch in order to maximize federal grant opportunities. Moreover, this position would be funded by Proposition 99 funds and not target the general fund. The use of Prop 99 funds makes sense since the U.S. Surgeon General has repeatedly linked tobacco usage and diabetes, even making the specific causation in the report that it has been handed out to you. I fully support the spending of a minimal amount of money for the opportunity to maximize federal funds for fighting ever-increasing rates of diabetes in California. I ask this committee to support the creation of this grant specialist position with the Department of Public Health's Chronic Disease Branch.
Thank you. DHCS, any comment? DPH?
Mr. Chair, members and staff, Greg Oliva, Assistant Deputy Director, Center for Chronic Disease Prevention and Health Promotion in the California Department of Public Health. We greatly appreciate Assemblymember Gaines' interest in diabetes and also in identifying additional grant funding for the program. However, the department believes it actually is doing a good job in identifying appropriate grant funds for the program. We would actually oppose the use of the proposed funding to create that specific position in using those existing Prop 99 resources. And we're certainly interested in continuing to look at and strengthen our grants management within the department. And at this time, we don't have a specific proposal in mind on this matter. Thank you.
We have a member comment. Mr. Chu.
If I could just give in response to that, our colleague has just stated that there were a number of grants that we were eligible to apply for that we didn't, that our spending on diabetes is less than almost every other state. We have the lowest per capita funding for diabetes prevention. So do you disagree with those statements, or I'm wondering how you would address what has been pointed out?
Thank you. We were given a list of the specific grants that were identified by the California State Auditor that the Assembly member had mentioned. The vast majority of those grant opportunities were for clinical research in relation to diabetes. That's not work that the Department of Public Health undertakes. There were a few opportunities that were listed that the department was eligible. When we look at grant opportunities, we take a look at a lot of different options or criteria that we would follow as to whether we would expend the resource to apply for them. In some instances, we look and see if we think that we're going to be competitive in relation to who else applies for those funds, and whether we think that we have the capacity or the existing the prerequisite sort of activities that would make us competitive. In one of those, we didn't think that we were the best fit to apply for that because of the requirements that a lot of different community activities be in place. In the end, 2 small health departments were funded as a result of that procurement. So we don't do clinical research, and in instances, we do look at whether we think that we're going to be competitive for grant funds.
And how do you address the fact that our per capita funding for diabetes prevention is so low, and is there anything to be done to address that?
So the only sources of funds that we have come from CDC, and we've actually been quite successful in securing those. one thing that's happened in the last several years is that the CDC has changed how they funded categorical programs versus more coordinated programs. So there used to be, as the Assembly member alluded to, a California diabetes program. The CDC has changed how it provides grants to states and other communities to focus on more coordinated approaches to address chronic disease. So the grants that we've brought in now that do focus on diabetes also focus on obesity prevention, nutrition, physical activity, and in some cases also school-based programs. So we're currently bringing in about, over the next several years, $7 million through those grants, but they focus on a variety of other activities as well.
Appreciate that. Thank you. I just want to state as a comment, we all know the statistic around diabetes, particularly for young kids of color. 1 out of 2 Latino kids, 1 out of 2 African-American kids projected to get diabetes. And from my perspective, I don't think we've done enough as a state. So I'm just very interested in figuring out what we can do to do more.
And I'll just ask a follow-up question as well for the department. It sounds like you feel like you are staffed up enough to address all potential grant funding opportunities, and the ones that were mentioned in the Bureau of State Audit's report were ones that you intentionally thought you may not be competitive for, so didn't seek. I just want to make sure I'm real clear about that. It sounds like there's a proposal here to provide you with more resources to pull down more funding, especially given the lower per capita rate for California. But I just want to be real clear that you're saying you think you have it covered with your existing staff resources.
We believe we do. We believe the vast majority of those opportunities just didn't fit the mission of the Department of Public Health, and that was clinical research. And of the ones that were more applicable, we didn't feel that we would be competitive against other applicants in the country.
Okay, because it also seems like there's sort of an investment that you put in when you submit an application, and you kind of make that decision based on the resources that you have. If you don't have a really high possibility of getting the grant, you might not want to apply. But if you had more resources to expend, you might take a few more risks or lower the threshold. You know, for not absolute, maybe you're not 90% going to get it, maybe you're 80% going to get it. So it's worth a try, and you're putting more applications out there, and maybe you didn't think you would get it, but you do. So I mean, I know there's sort of a cost-benefit analysis, and you got to figure out how to expend your resources most wisely, and you're on the ground, so you know how to do that. But it sounds like Assemblymember Gaines has a really strong passion. I mean, I know she does, because we've co-authored bills together on this in the past, and this is something our state really needs to get a hold of, and we don't have good control over this issue yet. So it's a little bit perplexing to say that you don't want more resources to help pull down more funding, but so I'm trying to understand, and I think I got a sense of where you're headed. So thank you.
Thank you, Mr. Chair. We have an abysmal record of serving our diabetics in the state of California. We spend 3 cents per capita, and that is the 50th in the nation. So we don't have a very good record. From July 1st, 2012 to June 30th, 2014, we found that more than 40 grants related to diabetes for which state agencies, including public health, were eligible to apply. So this is a minimal request, about $150,000 request, in order to serve those people that are suffering with this growing epidemic. I think that it's something that we should look at, and I would hope that you could support this.
Thank you. Let's go to Department of Finance. Any comment?
No comment this time.
LAO? No. Okay, thank you. Any comments from members of the public? It looks like we have one.
Jerry Chaffee, representing the California Chronic Care Coalition. One of our programs deals with spreading best practices of dealing with the complications of diabetes. I just want to add 2 statistics that haven't come up that why more needs to be done on diabetes. One is 1 out of 10 people in this country has diabetes, and the numbers are going up. So there's a cost there. Number 2, the cost to a person who has diabetes, the average cost is $14,000. That includes medications, doctor visits, and so on. So if it does cost the state money, what about the people who are on Medi-Cal? The state's picking up that tab. So for a very small investment of getting some grants, you more than pay for itself, just tremendous amounts of money. So there are these hidden costs, and you're not looking at them, and you should. Then you'll see what the real costs are.
Thank you. Any additional comments or questions from members? Okay, thank you. Assemblymember Gaines, I just want to thank you for your commitment to prevent diabetes and for moving this proposal forward. And you've given a lot for us to consider, so thank you.
Thank you. And don't forget that $29 billion a year for the state of California. It's a huge investment that, for a small investment, we can make a big difference. Thanks so much.
Thank you. I see Assemblymember Waldron has joined us. We have your prescriber prevails policy budget proposal.
This is just what I'm handing to them. Thank you, Mr. Chair and Committee. We're bringing up some handouts. Also, there's just a wealth of information on this, and I didn't want to spend all the time reading all of it, but Prescriber Prevails has been implemented in other states because the poor, underserved patients seeing their doctors in clinical settings do not have access that others who have fancy private health plans have. We have, in essence, created a two-tier health system. Formularies and step therapy are not always sufficient to treat certain vulnerable populations. Because of this, the federal government enacted Medicare Part D, which included 6 protected classes of therapeutic drugs. These categories and classes of drugs meet 2 very important criteria. Number 1, where restrictions of attaining the correct drug would have major or life-threatening consequences and or must be taken for life. And 2, where there is a significant need for the disease or disorder to be treated by multiple drugs within a specific class, such as AIDS, HIV, and others. The Prescriber Prevails Act would model the protected class structure after Medicare Part D, creating a similar protected class structure for drugs prescribed by a Medi-Cal beneficiary physician that would be covered under the Medi-Cal program. These 4 classes include antiretroviral for AIDS, HIV, antipsychotics, immunosuppressants for anti-rejection, and epilepsy anticonvulsants. These conditions are life-threatening and unique. The first treatment is typically the best chance to get the disease under control. Now, Prescriber Prevails has been a precedent in other states, in the Medicare system in New York, Florida, Indiana, Michigan, and in other states using commercial plans, and works within the prior authorization process and allows managed care plans to still create their own formularies, carve out certain drug classes. It also allows for generic drugs. Prescriber Prevails merely requires Medi-Cal managed care plans to implement this for medically necessary prescription drugs within these 4 classes. Now, I have handouts. I won't read them, but they basically, one is a cost versus the savings of using Prescriber Prevails. And one of them talks about the step therapies and how much that costs in the long run versus the utilization controls under Prescriber Prevails Act and reducing community viral load, better quality of life for patients, and how it's actually costed in the Cornell study, which you also have available. And I'll just touch base because according to the study of New York, which has had Prescriber Prevails, started for antipsychotics and then was increased to AIDS, HIV. They're recommending it for all drug classes. When it was actually costed, if it applied to all, less than 0.5% of patients who require a prior authorization, not all patients in each class, but only those requiring a prior auth, would actually have a doctor that would apply for Prescriber Prevails Act. Of those, only 1.3% would actually be issued a prescription under the Prescriber Prevails Act. And according to a New York AIDS HIV physician, we're spending thousands to save millions of dollars later, and it's only used in very rare and minimum cases. So I wanted to talk about the concept here in Budget Committee, that it does strengthen the doctor-patient relationship. Shortening the time frame under prior auth is all it does to get an answer sooner for every patient in very limited specific circumstances, and the physician must meet all requirements professional knowledge, and the FDA competed in the request. The Prescriber Prevails Act does not circumvent prior authorization process. The managed care plan can say no. The Prescriber Prevails Act is not a dispenses written free-for-all. The Prescriber Prevails is implemented for 4 specific controlled drug classes with a prior auth process and appeals. Under all prior authorization requests, not all patients, it's invoked only 0.43%, so under half of 1%, and is accepted 1.3% of those requests. So it's a very minute number. It allows a physician in a medical environment who does not have resources to invoke this for very select patients. So we're actually giving a voice to the underserved community who are right now do not have the ability to attain these drugs, because in the clinic setting, the doctor just merely doesn't have the time to go for all these prior auth step therapies. So in concept, in closing, this bill passed Assembly Health Committee in 2014, 18-0, and in 2015, where we actually delineated in the bill all the cost controls, with a 19-0 in Assembly Health. Our difficulty now, we've been working on this for 3 years, is getting the costing, appropriate cost for implementing, because of several factors. We've been unable to attain numbers for how many people are being treated under each disease in the protected class, how many TARs are issued in each of these 4 classes, how many approved TARs are there, what would the costs be, and then basically considering the fact that it's not every patient in the category that we're going to be, giving them higher tier drugs. As said, it's only very few, 1.3% of half of 1% of all prescriptions. So, and AIDS, HIV, and antipsychotics already have carve-outs, which can account for savings. There was $10 million that was put on this bill back, the first bill, which didn't have the utilization controls. That's why we put them in, because it's not a free-for-all and it's not every patient. I believe the cost would be anywhere between, as in New York, they were basically a wash. The Assembly in New York said there was really no significant cost increase at all, and they did it for all drug classes. I would say it could be between 0 up to 2.9 million, but all I'm asking from the committee is that I could work with you to get all of us at the table to really see what this would cost, because it could save people a lot of suffering. It could save lives. As I've delineated, I've included the prior auth process of how it's done in New York. It has appeals, multiple levels. It shortens the time frame for prior authorization. Also, AB 73, the bill that went through Health Committee, and all the utilization controls in that. And the Cornell study also. So I would be happy to answer any questions. And I'll just close with this. According to the Cornell study, of the 42.5 million prescriptions filled in New York in state fiscal year 2010 to 11, an estimated 0.1% was shifted from one drug to another based on Prescriber Prevails. This should not be material enough to affect the state's managed care plans. And that's right from the study. Thank you.
Let me ask if the department has any comments on the proposal.
No, we're currently analyzing the bill, including the potential fiscal impacts.
Okay. How about Department of Finance? Leo? No comments?
None at this time.
Okay. I think I'll just make one comment, and this is something that that our colleague knows. From my perspective, I think we want to ensure that our patients are able to get the pharmaceutical drugs they need, and certainly if the prescriber is able to or believes that this is important, that should happen. That being said, and we've had this discussion in the Health Committee, we don't have any ability to think about cost controls when it comes to particularly high-end specialty drugs. And certainly, as has been laid out in the staff analysis, we know that there are many new pharmaceuticals and treatments that are emerging rapidly, and it is creating enormous challenges for us in government. We can talk, for example, about hepatitis C and the $1,000 per day, $84,000 per year treatment that has blown up our budget by $300 million just for one pill. If we had that money, we could backfill all of the recent cuts to Medi-Cal, and that is just one drug. And so I'm certainly, I was supportive of this in the Health Committee, and I think it's something that we should be open to, but there's a broader question that I don't think we've grappled with, and I do hope we can all work together to figure that out. So with that, unless there are any other comments from colleagues, why don't we go to public comment?
Bill Remek on behalf of the FAIR Foundation, which is based in California, a national transplant advocacy and support organization. And this is essential for non-Medicare patients who've had heart, lung, liver, kidney, and other organ donations, recipients. It's essential that there's continuity in their medications, and we ask for your strong support on this concept. Thank you.
Next speaker.
Jerry Jeffy, representing the California Chronic Care Coalition. Just 2 points. First, we strongly endorse all the remarks that the Assemblyman made and agree with all those. Second, I just want to give a quick example of where this does make a difference. One of the categories is epilepsy that's involved. The average cost to a person who has to go into emergency room has epilepsy because of a mistake in drugs or things that don't work is $8,000. So right there, there's, that's either going to cost in a Medi-Cal or an individual. That's an enormous sum of money that could be avoided by getting the right drug at the right time. And timing is critical for people with epilepsy. You can't fool around with different types of drugs. If you make a mistake, it could be life or death. So just want to mention that as this really does have real effects on people's lives. Thank you.
Thank you. Next speaker.
Members, John Valencia, representing Synovian Pharmaceuticals, a company that manufactures CNS, central nervous system medications for the treatment of epilepsy and psychoses. We think Ms. Waldron's proposal complements perfectly the authority that the administration sought last budget cycle for the adoption of coverage policies and ultimately payment policies to benefit managed care. We're anxiously awaiting the progression of the stakeholder sessions. We think this proposal complements that perfectly so that we can develop coverage policies for these disease states and for the medications that treat them, and ultimately open the door for business arrangements with the state so that we can provide available resources that will help our colleagues in managed care. Thank you.
Final speaker.
Yeah, thank you, Mr. Chair and members. Nick Luizos on behalf of the California Association of Health Plans. And with all due respect to the Assemblywoman, and just going by the proposal as it's laid out in the analysis, and I'm not privy to what was handed out to the members, we do have a lot of concerns with this concept. As Assemblymember Chu pointed out, the governor has reserved hundreds of millions of dollars to deal with one particular condition. And while this proposal doesn't necessarily impact the hepatitis C issue, we believe that health plans are expected to be good stewards of either premiums or state funds, and a policy that would require plans to pay for anything that's prescribed, we think it goes in the wrong direction. There needs to be some oversight, particularly on costly drugs and on drugs that have side effects and other ramifications. And so we have concerns. We'd like to come in and talk to the Assembly member and her staff about what the specifics of the proposal are. But based on what's in the agenda today, we have some serious concerns. Thank you.
Okay. Any final comments?
Could I just say one
Absolutely.
thing? And I'll be happy to work with the health plans as well. One of the things that we definitely added in was, let's see if I can find it. We do have within the cost controls that the plans can also reject the doctor's request. An appeal can be made, and then it can also go to the board for a hearing of an independent review by the Department of Managed Health Care. So there's quite a bit of authority in this. And, one of the concerns is we just want to make sure that all the compendia is met, all the reasons for the drug, because once you do step therapy and fail and you're on combo drugs, that whole class goes out the window. And that's where the drug resistance comes in. And that's why it's so important that we, do this the right way. So thank you.
Great. Thank you very much. We're going to be holding open all of these various stakeholder proposals during the course of the upcoming budget. And with that, why don't we go to our final issue with the Department of State Hospitals regarding the Metropolitan Security Fence proposal. If I could ask the Department of State Hospitals to step up to the panel. And please feel free to proceed when you are ready.
Thank you, Mr. Chair. Pam Allen, Department of State Hospitals, and with me is Stephanie Clendenin, Department of State Hospitals, who will be presenting the Metro proposal.
Good afternoon. Stephanie Clendenin, Chief Deputy Director, Department of State Hospitals. With this April 1 finance letter, we were requesting $3,636,000 for preliminary plans and working drawings to add additional secure bed capacity at our Metropolitan State Hospital. This request changes the original governor's budget proposal by requesting both preliminary plans and working drawings to speed up the project by approximately a year, and also represents a reduction of the estimated total cost by nearly $5 million. The proposed project will increase the secure bed capacity at the Metropolitan Hospital by 505 beds, netting approximately 200 unused beds which could be used to serve forensic patients, and most notably the growing number of incompetent to stand trial IST patients. The project proposes to fence the skilled nursing facility, which is a 129-bed building, and the continuing treatment west buildings, a 376 buildings with a 16-foot correctional level security fence. The project also includes expanding the visitor center to be able to serve the increased forensic population. The current visitor center only accommodates up to 15 occupants, and the new visitor center will be able to accommodate up to 50 occupants. The project also proposes to fence the adjacent park, which is necessary to adequately provide for secure space for evacuation in the event of a fire. And an added benefit is that the park, once fenced, will also be able to be used to provide valuable outdoor treatment and recreation space for the forensic patients. The proposal also includes providing a restroom in the park, and also includes some utility, roadwork, and relocation of the parking lot, since construction of the fence will cause a displacement of the parking and will cut through existing roads and utility lines. The project continues to be necessary to address the significant growth that we've experienced and continue to experience in our forensic populations. We have seen a significant growth in our IST referrals from the counties, and as a result, our IST population has grown by 19% in the past 4 years. We've also seen an average 5% growth in the past 4 years across our other forensic populations as well, being our sexually violent predators, our not guilty by reason of insanity patients, and our mentally disordered offenders. To increase capacity, we have opened additional units. We've had to overbed on other units and have established a jail-based competency treatment program that provides restoration of competency services in the jails. In the governor's budget, we have proposed opening units at our Atascadero, Coalinga hospitals for a total of 105 beds, and San Bernardino County recently has approved an expansion of the ROC program there by 76 beds, which will serve additional patients from San Bernardino County and LA counties. In regards to the ISTs specifically, we continue to be under significant pressure by the courts to reduce the IST waitlist and to admit IST patients within 30 days. As of May 4th, there were still 296 patients pending placement at a state hospital. This is down from 365 in July 2014. While it has come down some, it still continues to be high, and patients continue to wait more than 30 days to be placed in a state hospital. In summary, this critical capital outlay project is a critical component of our capacity expansion plans that, together with other expansion efforts, will more effectively provide for current and future population needs, address the continuing IST waitlist, and could help to reduce overbedding in our hospital system.
Thank you very much. Let me ask if the Department of Finance has any comments.
Carlos Ochoa, Department of Finance. We continue to support the governor's proposal at April 1.
Okay, and from the LAO?
Drew Soderborg, Legislative Analyst's Office. We recommend that the legislature not approve this proposal as activating new beds, which is the ultimate goal of the proposal, represents the least cost-effective way of adding capacity to DSH. To the extent the legislature finds that additional IST capacity is necessary, we recommend that less costly alternatives be explored first, such as further expansions in the Restoration of Competency program. I'd be happy to take any questions that you might have.
Thank you. Any questions or comments from the committee? Okay, any public comment? All right. I think that might conclude the presentation for today. I know this item has been recommended to be held open to allow for additional time to review. I want to thank the panel for your presentation. And with that, unless there's any more business in front of the committee, I think at this time we are adjourned. Thank you very much.
Thank you.